and good evening. I'm Melisa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. Now, in 2023, Malaysia recorded medical cost inflation of 12.6%, which is more than double the global average of 5.6%. Now, what's fueling this surge and who bears the brunt of this burden? Joining me on the show is Professor Datuk Dr. Syed Mohamed Aljunid Syed Junid. He's Professor of Health Economics, Policy and Management at the Department of Health and Community Medicine at IMU University. He's also the President of the Malaysian Health Economic Association. Thank you so much for being on the show with me today. I'm going to start with a big question. The biggest question there is on the show: why is Malaysia's medical inflation so high, significantly higher than the global average, more than double? What do you understand to be the factors driving medical inflation?
Okay, thanks, Melisa, for having me in this session. Let's look at the figure again, the medical inflation figure that was quoted by many people. Malaysian scenario was actually stated as 12.6%, and comparing to when we compare with the global average of 5.6. But when I look out at the various report, the global figure is actually higher than that. It's not 5.5 to 6%. There was a report saying that the global average now is around 9.9%. For the medical inflation, comparing all the countries, maybe 5 to 6%, we are talking about maybe high-income country. Why is it that medical inflation are much lower compared to countries like Malaysia and all that? Maybe because one of the reasons is that their health spending is very large. So a small increase will not be a major issue. Whereas Malaysia, we spend only about 4.5% of GDP. You compare with the global average of about 9% of the double of what we are spending. But if you look at the whole figure of medical inflation for Asia countries, we should not be so alarmed with the Malaysian figure of 12.6, because Indonesia recorded 13% increase in the inflation, and nearest to us also is Vietnam. Vietnam actually recorded 20% increase, in medical inflation. Thailand was around 10.7, and Philippines was actually the highest in this region, about 32%. So why is it these countries are having increase in healthcare costs? From the economic perspective, we can actually divide this into two big areas, two parts of it. Number one is the demand side, which is looking at the population and the demand for the healthcare services. But we must not forget the other side, which is basically the supply side. Demand side, we're looking at the population. Why is it our population are actually spending a lot more resources than before? Basically, if you look, two important things is, number one, in our population now we have a lot of issues with the chronic non-communicable diseases. Basically, diabetes, we have about 18% to 20% of our population with diabetes. Diabetes is a chronic disease. It's one of the chronic diseases that need long-term care. Furthermore, in Malaysia, we know that nearly about 25 to 30% of our diabetics end up with a chronic kidney disease. And chronic kidney disease, if you go into a very high stage, which is stage 5, they need dialysis, and that's very expensive. Cost of chronic kidney disease alone for 1 year is around 39,000 ringgit per person. That's a huge amount. The second issue regarding our chronic diseases is also hypertension. About a third of our population have hypertension. Hypertension is also another sort of a burden for the country to manage. And related to that is cardiovascular diseases. And we must not forget about our cancer cases. Cancer cases is on the rise. And the sad thing about the situation in Malaysia now, for breast cancer, for example, it was stated in one of the reports, nearly about 60% of our women, when they have breast cancer and they present it to the public facilities, is already in the very late stage, stage 3 and stage 4. And cost of treating this is very, very much higher compared to if we are able to catch them early through screening and other things. There's one factor, the chronic non-communicable diseases prevalence is going up. Risk factor to that, obesity, for example. 50% of our population are overweight. And more than 60% of our population also have a high cholesterol level. These two is actually precursor of many chronic diseases. So to treat this, we have to spend a lot of money, and that is one of the reasons why not only Malaysia but countries in this region spend a lot of resources.
So those are the kind of demand side that you're talking about. What about the supply side? What causes medical inflation on the supply side?
Always in any situation, the demand and supply side would be interacting. The supply side, we are talking about facilities, doctors, and also all other components in the services. One of the very big chunk of the supply side expenditure is on hospital. The more patients are admitted to the hospital, more hospitalization rate, for example, the cost is going to go up. That's why we are encouraging people to actually seek primary health care rather than going for admission unless it is necessary. Within the hospitalization and also the what we call secondary care and tertiary care, one of the big component of that is drugs. Malaysia spent nearly about 6 to 7 billion per year on drugs alone, and that is quite expensive. If you look at the total expenditure of Malaysia in public sector, is around 41 billion. So 6 to 7 billion is nearly about 15-20% of the whole total expenditure. This is quite large in that sense.
Are we buying expensive drugs, or is our currency just weak?
I think both situations can happen, but our currency is improving now, so that is not the issue. I will touch upon the how to handle this later. The other issue is also medical equipments as well as investigative procedures and equipment, for example, MRI, CT scan. In countries like European region and also in OECD countries, many of these countries have much more control in terms of the use and also deployment of these facilities. For example, in Germany, a good example, they have a certificate of needs. You cannot just buy a CT scan or MRI without proper approval from the government, and they look at the population needs. The theory is that if you put in any facilities, any equipment, it will be overutilized. It will be utilized because when the company bought this equipment or invest in this, they would want to actually recoup it, and that may lead to unnecessary use of the services. So in economic term, the use of unnecessary services is called supplier-induced demand. This is where the demand are being created by the supplier. Who are the supplier? The hospitals, the doctors, and all that. They end up providing services that may not be necessary for the patient. For example, if the patient need only once to go through MRI, why you want to do it 2 or 3 times, for example. So these are important factors that we must not actually forget about it. The other important factor from the supply side is the way that we reimburse the hospitals. We pay the doctors, for example. Currently, in the private sector, the payment to the hospitals and to the doctors, we use the method what we call fee for service, which means that every items that are being provided to the patient, drugs, investigation, length of stay, for example, is being locked down, and then at the end of the day, the bill is presented to the patient. So the more drugs, the more investigation you do, for example, the longer the patient stays, then the bill is going to be bigger. Alternative to that, in many countries they implemented a package payment where the payment to the doctors and to hospital, they use other method, what we call the diagnosis-related group, or they pay by global budget. This is a much better system where the package is being decided even before the patient gets admitted. This is what we call prospective payment. Our system in Malaysia and many other countries that are not actually moving into this is actually called retrospective payment, where the final bill you will not know only until when you are discharged.
You get the bill.
For prospective payment, like using where we use diagnosis-related group or DRGs, for example, what we call case mix system, or global budget, for example, we decided the package even before the patient was admitted. So there's no way that the hospitals or the doctors can inflate the bill. So this is it will lead to much more control in terms of cost.
Okay, I'm so curious to learn more about the package payment approach, but I want to ask you, if we focus on just say the supply side, let's not look at the demand side factors, variables of medical inflation. So the supply side, has government policy or the lack thereof contributed to the rising medical costs? Yeah,
of course, because government is the main regulator for any health system in the world, including the private sector. For Malaysia, we have a Ministry of Health. For example, when government controls in terms of the licensing of equipment, licensing of for hospitals to purchase expensive equipment like MRI, CT scan, it will help to reduce unnecessary use of these services. So that will have an impact. And number two, when the government, for example, embark on a mechanism where it will allow only hospitals to be reimbursed based on package payment rather than the fee-for-service method, it will have an impact in controlling costs, and it will to a certain extent manage the cost much easier with this package. Policy is very important here because it will actually have an impact on that.
What about Malaysia's current structure of kind of private public healthcare and private healthcare? The insurance industry places some of the blame on private hospitals for the rising medical costs. Where do you stand?
Yeah, actually private insurance is very interesting in this country. Malaysia is one of the exceptions among many of the countries that in middle income countries, and also a country in the ASEAN region where we do not have a social insurance program, and we depend on private insurance. Studies have shown that around 26% of our population now has subscribed to some form of private insurance. So private insurance plays a very important role. But private insurance also have a lot of influence on the overall costs, and also might contribute to some extent on the inflation. For example, most of our private insurance in this country, most of it, I think until today, all of it are actually reimbursed the hospital based on fee for service. So they are not reimbursing on package payment. So this actually might to a certain extent leads to the term that I used just now, supply-induced demand, and the bills can be inflated easily. And this will lead to a lot of problems if we don't actually move towards a package payment.
So is there a way to regulate private hospitals without shifting our current approach of fee for service?
Well, there are many things that we can do. For example, recently the government tried to introduce the co-payment for the private insurance. So it is debatable. There are a lot of issues that we can talk about, because although theoretically, when you actually put in what we call co-payment, theoretically people said that it will be able to help to decrease the premiums, and that might have an impact on the overall cost of healthcare. I certainly don't believe in that, because basically, if you are actually putting in a co-payment, there will be an additional resources that need to cough out by patients. And this, at the end of the day, will increase the cost, because these are additional costs that you have to put in. And furthermore, this policy have not been properly refined and studied, because they give exemption of the co-payment to public facilities and also to patients who suffer from chronic non-communicable diseases. So exemption to the public facilities when people activate their private insurance will actually lead to more patients will be actually shifting the demand to the public facilities. And this will actually lead to a lot more people have to wait longer in the public facilities, and public facilities will be overcrowded. So that effect have to be studied properly before we can actually go in and implement this co-payment. So of course there are two types of co-payment, the deductible or co-insurance. Both have almost the same similar effect in actually might lead to increase in healthcare costs. And there is no good track record to show that with increase in the introduction of the co-payment might lead to lowering down of the premium. It doesn't show that. There's no history, there's no good track record. Most of the time, the premium are going to increase from time to time, and this will lead to more burden to the population. And remember, currently our population is paying around 30 to 35% of the total expenditure from our own pocket, the out-of-pocket payment. This is one of the highest in the region. If you compare with the OECD countries, they spend only half of that, but 15% of the total expenditure for an out-of-pocket. Why out-of-pocket expenditure is bad? It will lead to a situation where people will have to pay a lot more money on their own, a lot of issue of inequity. Those who are actually in lower income group will be affected more. It would also lead to overcrowding of the public facilities. The WHO standard, the WHO set a standard of out-of-pocket expenditure should not be more than 20% of the total health expenditure. We're already over than that. Countries like Thailand, for example, with a good social insurance program, they spend probably about 8 to 10% of the total expenditure from out-of-pocket.
Right. Prof. Syed, what do you then say to those who argue that we cannot continue without this co-payment system, that co-payments actually is the norm for many other countries outside, and to sustain our healthcare and the level of healthcare that we desire, which is a high level of healthcare, we really need to look at co-payments as the future.
Yeah, I would like to challenge that statement basically. If you look at many other countries, although they have a co-payment, that the way the insurance, private insurance operates is different. We in Malaysia, we allow the private insurance to actually calculate the premium based on what we call the risk rating. The higher the risk that you have, for example, if you have diabetes, hypertension, you got to cough out a lot more money to pay the premium. Other countries like in UK, in Europe, for example, they don't allow risk rating. They go for what they call community rating. Community rating means you share the risk quite equally among the whole population. So at the end of the day, you don't differentiate people who have diabetes or hypertension by paying different premium. The thing is, it happens because they pool all the risk together. Private insurance in Malaysia, they are actually operating on their own individually. So they don't pool, their pooling of risk is very small. As a result, the only way that they can actually get profit from the system is to increase the premium. So the co-payment actually will not help actually in this, but it make things worsen. But at the end of the day, the way that the insurance operates in the future have to be changed. We need to go into community rating rather than risk rating that has been implemented or currently being used by our private insurance in the country.
Okay, talk to me about changing some of the norms, the status quo in the country. You talked about the fee for service, changing it to a kind of package payment approach. You talked about changing the risk rating for individuals to a community risk. How do we go about thinking of shifting the way industry has operated for many years in Malaysia? Let's go with the package payment first.
Yeah, I mean package payment. The reason why we want to go into that because it will actually help for us to define the cost properly from the day one before even the patient admitted. For example, if somebody suffers from, say, for example, stroke, under the package payment, there is a best practices has been used to calculate the payment. We look at what is the good length of stay for patients to stay, what are the risk factors related to that. All these are being calculated for, and there is a very standard way of doing it. And finally, we decide if the patient have got different risk factor, different comorbidity, it will have a different pricing. So that is decided irrespective of what the doctors are trying to do in the hospital. So for example, if the best practices for stroke, for example, severity level 1 is 7 days of stay. So the tariff will be calculated based on 7 days of stay. If the hospital keep the patient longer than that, they will not get any extra cents from that.
Would doctors have a problem with that because it may hamstring them or tie one hand around their back in providing the best care for their patients?
The best care may not be the most inefficient. So the best care is, well, the quality is good, and secondly, it is efficient, which means that they don't keep the patient unnecessarily longer in the hospital. When the longer you stay in the hospital, may not be good for patient as well. You are exposed to nosocomial infection and all that. And number two, the drugs that are being used, it will be standardized under the package payment. You don't use drugs which are actually not proven to be cost effective. So all these are taken into consideration rather than giving an open bill to the hospital to decide how much they're going to pay, they're going to get paid at the end of the stay. So in other words, you look at you design the package properly, looking at the best practices, then the payment is made based on that. Basically, the doctors, of course, they will have some clinical freedom. That's why in many countries that when we want to do a package payment, we have to legislate it. There must be a regulation put in place that if they want to be part and parcel of the National Health Financing Scheme, they must agree to actually they must agree to the payment method that they have to accept this. You are going to be paid using this package payment. It will help a lot actually to reduce the unnecessary cost to the patient and also to the nation.
What would incentivize private hospitals to want
go for this?
I mean, I can't see any incentive on the private hospital part.
Most countries, when we implement this, it is actually part and parcel of the National Health Financing Reform.
Okay.
The hospitals will get volumes because patients are able to choose to go to public or private facilities because the government are going to reimburse them, to reimburse the hospitals. So patients will not have to pay from their own pocket. They only pay the premium, which is organized by the government agency. When they go there, they will get the services. So the hospitals now, the private hospital will have a chance to get more patients. The bed occupancy rate in private hospital now is also not that high. They have a lot of capacity there. While patients are actually flogging the government facilities because they want to avoid being paid. They want to avoid actually paying extra money or paying all the resources. But now they go to the private sector. They can choose to go there. Their waiting list is much shorter. The facilities also much more attractive to them. They're more comfortable, but it's going to be paid by government. So incentive is that they are assured of getting a good volume of services, and they will be part and parcel of the whole health system development.
Have you heard any kind of feedback when you bring this up in terms of when you talk about medical inflation, you bring this this need for reform? What's been the response?
Oh yeah, I mean, even Ministry of Health now is looking at moving toward a package payment using the RG. There's a committee that has been set up by Ministry of Health.
Is this the outcomes-based type?
Yes, of course.
Okay,
it's related to we have to relate to the outcome because this is one of the things. They will get more incentive if the patients have less complication, the surgery was successful, for example, and if the patient were able to be discharged earlier, there will be an incentive being built. It is not just a payment, but there are a lot of incentive schemes that are given. And they use, for example, less expensive drugs, generic drugs, for example, that are effective. They will get incentive for that.
Are there any unintended consequences? So if we do shift to this, and think about the other models of different countries, if we were to shift to this package payment model, what would be some of the consequences?
Yeah. Well, basically, we have to do a lot of explanation to the doctor in this country. In other countries, people know about 120 or 190 countries has implemented this system. Actually, Malaysia and few other countries is exceptional. Indonesia has started it off since 2007. Thailand is earlier than that. Philippines, for example, in 1988, they already started the system. So in Vietnam, I think since in the late 90s, they have done this. Malaysia is exceptional in that sense. So there are, of course, there will be, to a certain extent, loss of freedom from the doctor. They cannot just prescribe anything that they like, you know. They can, but it will not be reimbursed unless you follow the practice. But here, it will be more control. And if we are serious in terms of moving toward efficient system, more cost manageable system, this is the way forward, actually.
So when we think about all the, you laid it out for us kind of beautifully, all the factors that drive medical inflation. What strategies are within our grasp or on the table to be able to control it so it's not so bad, 12.6%? Yeah.
So when we talk about medical inflation, the intervention that we should do in order to mitigate these issues, we cannot run away from raising healthcare costs. Basically, Malaysia is moving towards a system where we will have more resources to be actually allocated for healthcare. I think if you look at Health White Paper, there's a statement saying that we want to increase the public expenditure to at least 50% of what we have now. Now we are spending about 2.5% of GDP for public facilities. We want to increase it to 5%, for example, double of what we're going to have. But where is this money going to be used for? So if you want to control medical inflation long term, the best way to actually invest is on prevention. So I think we talk about chronic diseases like, for example, cancers. So cancer can only be treated or managed well if we have a good mechanism to screen them early. For example, mammogram, we should actually introduce it in a more systematic way than we have now, so that we don't have issues of 2/3 of the patient who come to the facilities presented very late situation. We have other things like, for example, cancers like screening for colorectal cancer. Colorectal cancer is on the rise at the moment. It became, I think, one of the top 3 cancer in Malaysia.
And it's always late stage.
It's always late stage. So there are a lot of intervention that we can do to screen for colorectal cancer. For example, we can use fetal occult blood, and now some countries are developing blood tests through genomic testing to predict whether the person will have colorectal cancer early or not. And of course, the colonoscopy and all the other intervention was also used. So this has not been well implemented in Malaysia. That's number one. We have to go for prevention. Number two, again, prevention. It is actually a primary prevention. Primary prevention means we should try to actually do a lot more health promotion make people, give incentive for people to exercise, stop smoking, which is actually one of the issues that we are having, which is actually unhealthy lifestyle. Take good food, for example. We should not encourage people to be to take fatty food, for example, sugary food, for example. So all these need to be improved from time to time. So we need to actually do this in a very systematic way and spend more money on the preventive services. So that's on the demand side. Then I think we can do a lot of this. And the other thing is that about 8% of our population are elderly. By 2030, 2040, more than 15% of the population will be elderly. So elderly care is very important. So we have to focus on them because studies have shown that 75% of our elderly population will suffer from at least one chronic non-communicable disease. People are living longer, but the cost at the end of their life is very expensive because of this condition. So I think management and also treatment for the elderly population must be reorganized. A lot of our elderly population may not have access to facility because for those who are working with a pensionable scheme, it's okay. But what about those who are not non-pensionable scheme? They have to cough out money. They are not working at that time. So we must develop a mechanism so that our what we call warga mas, the management of these health services for the warga mas must be emphasized, and that at the end of the day will actually help to manage our healthcare costs. So that is on the demand side.
Yeah, and we haven't even gotten to the supply side, but unfortunately we've run out of time, and I could talk to you for an hour or two about this, but I thank you for sharing some of these important insights with us. Thank you for your time.
Thank you. Thank you so much.
That's all we have for you on this episode of Consider This. I'm Melisa Idris signing off for the evening. Thank you so much for watching and good night.